All righty. I believe we're live on the Center for Pharmacy Practice Facebook page now, so I'll just give it a second here and jump in. Thank you all for joining us today, both audience and the panelists. We've got a great group of experts here to speak to you all today about smoking cessation, which is the, I guess, more clinical term commonly known as quitting smoking. So I'm not going to chat for too long, but I just want to give you a little bit more information about these lunch and learns we've been doing through the Center for Pharmacy Practice Innovation. That's where you are. If you hadn't figured that out, this is the VCU School of Pharmacy CPPI Facebook page, and we like to hold these sessions about once a month just to kind of help answer some more general healthcare questions that maybe you might have, but you might not want to approach your doctor with or your health professional with, or you might not even realize that you've been mulling over these questions and that a health professional such as a pharmacist can help you with them. So that is what we're here to do. So without further ado, I'm going to turn it over to our moderator for the day, Vasco Pontina, excuse me. He is a PhD candidate here at the VCU School of Pharmacy, and he's going to kind of introduce our panelists and get us started. So Vasco, go ahead if you don't mind.
Thank you. Good morning, everybody, or good evening, depending on the time zone that you are. So before we continue, I have a brief disclosure to essentially announce that we need to acknowledge that there is a stigma around substance abuse, and this session by no means has the goal to further that stigma. In fact, we will center the discussion around strategies to quit smoking. Please note that no judgment is implied on the behavior of smoking or following or not following the smoking cessation treatments. So with that, I would like to introduce our distinguished panel. Let me start by introducing Dr. Kelly Good. Dr. Good is a professor at the Department of Pharmacotherapy and Outcome Science of VCU School of Pharmacy. She is the director of the VCU Community Pharmacy Practice Program and the VCU Community Pharmacy Practice Residency Program. She's worked for 10 years with the Community Pharmacy Practice Partners to develop enhanced patient care programs. Dr. Good is a board-certified pharmacotherapy specialist. She has authored a number of abstracts, special publications, and journal articles. She is interested in practice-based research and is developing a formal community pharmacy practice-based research network in Virginia. Dr. Good has given presentations on a wide variety of topics, including immunizations, practice-based research networks, medication therapy management, diabetes, asthma, and innovative community pharmacy practice. Dr. Good, thank you so much for joining us. The second panelist that I'd like to introduce is Dr. Thomas Eisenberg. Dr. Eisenberg is a tenured professor at the Center for the Study of Tobacco Products, which he also co-directs. In addition, he is the co-founder and lab director of the Syrian Center for Tobacco Studies, and he's also a fellow of the American Psychological Association, Division 28. His primary area of research is the behavioral pharmacology of drugs of abuse, focusing primarily on nicotine and tobacco. His work directing the Center for the Study of Tobacco Products is to develop and apply regulatory science to the evaluation of tobacco products and to train the next generation of tobacco regulatory scientists. Not only that, Dr. Eisenberg has authored a large number of peer-reviewed publications. In fact, Dr. Eisenberg was named by Clarivet Analytics as a Web of Science highly cited researcher in 2017 and in 2018. And last, but by no means least, we have Dr. Elizabeth Sadok. Dr. Sadok is a clinical psychologist at VCU Health. She received her PhD in clinical psychology from the Virginia Commonwealth University. Throughout her career, she has focused on helping people with a wide range of concerns, such as depression, anxiety, stress, adjustment, relationship problems, weight management, smoking cessation, alcohol and substance abuse, and trauma. Our treatment aims to empower people by helping them develop tools to live more meaningful and fulfilling lives. Her research focuses on the effectiveness of integrating mental health services into medical settings to provide patients with an holistic care. Dr. Sadok, thank you so much for joining us. As you can see, we have a great panel, and I look forward to hearing your perspectives. So, as I mentioned, today we will center our discussion on how to quit smoking. Just as a brief introduction, smoking and tobacco use is a behavior that is known to be associated with a significant economic burden. Smoking-related illness in the United States costs more than $300 billion a year, which includes more than $225 billion spent in direct medical care for adults, and more than $156 billion in lost productivity, which encompassed $5.6 billion in lost productivity due to secondhand smoke exposure. In fact, tobacco use is still the leading preventable cause of death and disease in the United States. Bear in mind that this is data pre-COVID, might have changed in the meantime. Cigarette smoking alone kills more than 480,000 Americans each year, and 60 million Americans are living with at least one serious smoking-related disease. For every person who dies because of smoking, at least 30 other people live with a serious smoking-related illness. So to discuss the strategies and effectiveness on how to quit smoking, let's turn to our panel. And I'd like to start with Dr. Eisenberg. In a general sense, what happens in my body or in my brain when I start with the first puff, when people smoke?
Yeah, thanks for the question. The answer is a lot of things, but I think that for a first-time smoker or a smoker who's having their first cigarette of the day, other than the sensory effects, the taste of the smoke, the feel of it in the throat, the thing that people notice most after one or two puffs is a feeling of dizziness or maybe a mild euphoria, sometimes called a rush or a buzz from that inhalation. And that's from the nicotine in the smoke being carried from the lung via the arterial blood right up to the brain. And it gets there within 10 seconds of the first puff. And there's a lot of receptors in the brain to which the nicotine can bind, leading to release of neurotransmitters that cause that rush or that buzz. What smokers, first-time smoker or long-time smoker might not notice so much is that along with the nicotine in the smoke, there's a whole bunch of other stuff, and not a lot of it is good. In fact, a great many chemicals, hundreds of chemicals, are toxic to the body. So of course there are chemicals that cause cancer. There's carbon monoxide that causes the cardiovascular disease that actually kills more smokers than cancer does. Various other toxicants that lead to inflammation in the lung and over the long term lung disease. Another thing that smokers don't recognize is that while that first or don't always recognize is while that first puff leads to that rush or euphoria, subsequent puffs frequently don't. And in order to reacquire that rush or buzz, smokers will smoke more and more, and smoking more and more, especially over one day and then day after day, can lead to dependence such that it's very difficult for smokers to quit even when they want to and even when they try to.
So it's the development of that tolerance over time that essentially gets people addicted to the habit of smoking. Is that right?
Well, the tolerance helps drive the repeated smoking behavior, and then that repeated smoking behavior with that continual, these little spikes of nicotine going to the brain very quickly, lead the brain to make changes to try and reset to a normal non-nicotine level. And it's thought really that it's those changes that the brain is making that leads to that dependence. So yeah, of course, frequent self-administration is a precursor to that. But once you start getting changes at the cellular level in the brain, that's what drives this dependence that makes it really, really difficult to quit, even when folks are trying as hard as they possibly can to do it.
It's interesting because you mentioned that there are other things that kill more than cancer, and you've also mentioned the readjustment that happens on the brain because of continued nicotine exposure. So with that in mind, and please, the rest of the panel can join in as well. What are I would say like the physiological long-term effects of smoking, and also the behavioral long-term effects of smoking as well?
I guess I'll jump in and others can follow. I mean, I'd like the second part of your question a lot, the behavioral parts. And I think this is what we all need to understand a little bit better about what we're talking about when we're talking about drug dependence or addiction. I like to define that as a loss of control over drug self-administration, over taking in the drug. And there's no better indicator of a loss of control than when a person who's been using a drug, day after day, week after week, year after year, says, you know what, I'm done. I want to quit doing this. And so they either come up with a strategy on their own, or they reach out to a clinician and work out a strategy, and they try and they fail. That is the definition of a lack of control. And so for me, that's the biggest behavioral component that occurs over long-term use, is inability to control drug self-administration, inability to quit. And I'll stop there.
Maybe Dr. Good, can you please chime in on what are then the physiological consequences of smoking long term and quite possibly short term as well?
Certainly. So as Dr. Eisenberg talked a little bit about, so you have cardiovascular effects. So it can cause coronary heart disease, it can cause stroke, it can cause cancers. So lots of harm to the body in all different ways because of many of the things that Dr. Eisenberg talked about from the smoking. And it's typically it's coming from the smoking, the tobacco, and less of the impact of the nicotine itself. And so it's most of the other chemicals that are found in the smoking.
I think that perspective is really interesting because I remember in other circles, the non-academic circles where I'm also that I've also been a part of, sometimes when people were smoking, there was always this idea that, oh, such and such lived through like 60 or 70 years old, and that person did not develop any lung cancer. So smoking is not that bad. But the problem is that when people die of other unrelated causes, it's hard to tie it back to tobacco use. And the same thing with people that were exposed to others smoking. And I'd like to focus on that specifically. How can, we're talking about it as an individual or a behavior that has an individual consequence. How can my smoking be harmful to others? The CDC puts out this number that says that $5.6 billion are spent or account for lost productivity, which is a very significant number from an economical standpoint, due to secondhand smoking. So why is this? And what is secondhand smoking? Quite possibly, what is third-hand smoking? I've heard people talk about.
Yeah, so a lot of what we've talked about with what it does to the smoker, it can also do to other people. And so when we think about that secondhand smoking and thirdhand smoking and what it does to people that are exposed to it. So secondhand smoke is really that smoke that's coming out of the burning end of the cigarette, or the smoke that's breathed out by the smoker. And so that smoke contains about 7,000 different chemicals. And many of those are harmful or toxic, and 70 of those chemicals we know can cause cancers. So what happens is that there's really the same effects on the non-smoker when they're exposed to secondhand smoke. So you get bad effects for the cardiovascular system, coronary heart disease. You can get stroke and cancers to a person who has never smoked based on their exposure to that secondhand smoke. And so there's really no sort of risk-free level of exposure to secondhand smoke. And then the third hand smoke is a little bit different. So that's a little bit more of a relatively new concept. And that's the residual nicotine and other chemicals that are left on everything that's exposed to that smoke. So if you've ever been in a place where there's been a lot of exposure to smoke, you might see like a yellow film or coating. So that gets all over. That gets in the car where their smoker is, that gets on the carpet, that gets on surfaces. And so that people who touch those surfaces that are contaminated with that nicotine then are exposed to that. The other piece is there are gases that can be toxic that are coming off of that sort of third hand smoke, which is sitting on all the surfaces surfaces that are exposed to that. And so when we think about that, that's also reacts then with other indoor pollutants, right? So our air is not pollutant free. And so some of those can then interact and cause some cancer causing compounds and impact non-smokers, especially children. So we really need to think about a way to not have any exposure if possible to secondhand smoke and some of the residual left from that.
I think the last part of what you said really resonated with me, because I became a parent very recently, a year ago. And one of the things that as a parent, you're kind of always thinking is, how can I reduce exposure to essentially bad chemicals, and how can I protect our children? And so from what you said, what I realized is that babies are not exactly protected, even if the parent just goes out to the the balcony or to the deck out to smoke and then comes back in the house. That is not safe per se for the baby, because even though he wasn't exposed to the smoke or to the smoke that comes out of the parent's mouth, there's still significant exposure that can have bad outcomes for that baby. Is that right?
Most definitely. And we know that smoking is a risk to babies when they're in the womb. So for a mother that smokes, we see increased risk of infant death from women who smoke. And then when babies are exposed to even secondhand smoke when they're in the womb or as after birth, then they grow up with impact to their lungs. We also see secondhand smoke causing other problems in children. So you get what's called sudden infant death syndrome, where we don't really know what the cause of the death through that infant is. You can have children who have more severe asthma and have respiratory problems. Their lungs might not develop as well. So lots of impact to that. And as you mentioned, if you go outside and smoke and come back in, then it's going to be on your clothing. And then if you cradle that baby or breastfeed that baby, then they're exposed to some of those chemicals. And we still really don't know what the impact of that could be.
That's really important to know. We've been talking about the essentially the physiological aspect of smoking, and maybe we can transfer the conversation to a more behavioral. Dr. Sadok, why is it so hard to stop smoking? Can you tell us something about that?
Yes, absolutely. Well, I think a lot of that was covered so far in just talking about the physiological addiction of smoking. So you have that component, which makes it very addictive. But on top of that, you also have a lot of learned conditioning. So with smoking, there are a lot of triggers out in the world. And unlike maybe other substances, they're not hidden. They're a little bit more commonplace, where you might see someone smoking or watch TV and see a lighter or things like that. So there's a lot of learned associations that make it very difficult to stop, because there's so many triggers out there in the world. Smoking is definitely one of those things that it does take a long time and maybe some attempts to try to quit. Just because it's difficult doesn't mean it's not possible. There are more former smokers than current smokers. And so I think that physiological addiction plus the psychological component make it very hard. The other thing I want to add is that I think that a lot of people smoke as a stress relief. It becomes an addiction. It becomes more habitual. They just grab a cigarette as a way to relieve stress. But what we know physiologically is actually with the cigarettes, it increases your blood pressure, it increases heart rate, and the withdrawal symptoms as well create more stress. So people who smoke are sort of going through more waves of chemicals within their body. They do have more stress. But again, when they have those triggers, it's really common to just reach for a cigarette. So it's that automaticity of it and that like habitualness of just grabbing and smoking that I think make it really hard to quit.
I kind of relate to that, because I remember when I quit smoking, my strategy was I needed to learn what was going on in my brain, because I knew my brain was going to self-negotiate with me. Like, you have been so long, it's been like 10 days without smoking, you deserve this one. So I knew that was a negotiation that was happening within my brain. So I've also read in the CDC website that the most effective way to quit smoking or to essentially reduce smoking is to increase the price of tobacco. But that is not a tool that is at the hand, that is available to healthcare professionals. So with that, what are some of the most effective ways, in addition to increasing the price of tobacco products, what are the most effective ways that help people quitting?
I think that one of the most helpful ways is really to understand each person's personal motivation or their values. So what is it that's driving them? For some people, it may be economical. For other people, it may be connected to health, maybe having their children see them live longer for their children. It may be connected to attractiveness. It could be even connected to sexual functioning. There are so many different sort of areas that might motivate someone to quit. And so really being able to talk to someone and understand, at least as a clinician, talking to people, really understanding where are they coming from, what drives them, why do they want to make this change, is really helpful, because in those moments where you are negotiating with yourself about maybe just having one cigarette, it's you've been so good for so long. It's really important that those people have those values at the ready so they can remember, why are they putting in this effort? What is the point of this? So I think just kind of pulling out those personal motivations, and part of that comes from things like this, getting really good education about the effects of smoking in your life so that you can understand what it is that's going to motivate you. Maybe there's even something that has come up today, a little fact that really kind of sits and sticks there. And that's really helpful to come to mind when you're trying to make such a challenging change in your life.
You've mentioned that, and we have a question from the audience, and this is related with the triggers that you've mentioned that make it really hard to quit smoking, because people are exposed to other people smoking, but so one of the questions from our audience is, considering that there are so many triggers that can trigger the former smoker into smoking again. Is there any way that we can use, for example, like virtual reality, to simulate those triggers and to see what is the effect on that former smoker, to essentially like desensitize the former smoker to those triggers? And there was a question to you, Dr. Sadok.
Okay.
Is that can we use virtual reality? I mean, if the other panelists have experience using VR, that would be awesome to contribute to the discussion and answer this question from the audience.
Yeah, absolutely. I appreciate that question. I'm not familiar with using that myself. I think that could be a strategy, although with quitting smoking, I think in general, there is sort of a more sensitive window when you're trying to quit, where actually we would recommend that people try to avoid certain triggers. Some things are not possible, but things like preparing your environment, throwing away the ashtrays, throwing away the cigarettes, throwing away that lighter that you have that reminds you of smoking and like creates an urge, trying to stay away from places where people habitually smoke, as a way to sort of get over that hump. And it's especially those first 48 hours where like physiologically, I think you feel a lot of those strong urges. And then the first 2 weeks or so where I think like some of those psychological behavioral patterns are really being broken down. I know that in those moments when you do have an urge, it might be that I really like that idea of virtual reality. I don't know if the other panelists have a thought, but it might be good to sort of safely practice what we call surfing the urge. So with urges, usually they kind of spike, and I'm sure everyone can relate to this, whatever the urge, but smoking too. There's like a spike. It feels like it's going to go forever. And a lot of times right at that peak, people smoke. And so they don't really get to experience this idea that it's actually more of a wave. You have like that spike and it peaks and then it passes like a wave. So it's about 15 minutes or so where you really have that full like urge where that tension is really strong. And so actually, if you can distract yourself in that time period and maybe practice urge surfing, then you can get over the hump and gain more and more confidence the more and more times you resist the urge, and it can sort of build. But it's a difficult thing to do, but it's sort of a learning process that you can kind of wait it out in a way, as long as you don't then re-trigger yourself. Like, don't continue to stay in the presence of smoke and just expect that wave to pass. It will like crest again. So yeah, I don't know. I think that's a fascinating question. I would be curious if anyone else has any thoughts about the use of virtual reality, though.
I think it's a great idea. I did a quick search, and in fact, there are people working on that, that very thing, which I'm glad to hear. The reason why I think it's a great idea goes to something Dr. Sadak said earlier, that about these associations that develop between drug administration and the environment around us. And we've known this for decades. It was done, a lot of research done with rats and opioid administration. And one of the things we learned is that just like Pavlov's dog, you know, you ring a bell and then give him meat and he starts salivating, and then pretty soon starts salivating just to the ringing of the bell. The same thing happens, that preparatory response, salivation in case of the dog, happens in our body in preparation for drug administration. The way to break that link, as Pavlov and others showed, is to simply ring the bell and don't deliver meat. And over time, that salivation response will extinguish. So you would expect the same thing to happen with smokers if you present the cues that they commonly associate with smoking. The trick, of course, is that if you're a 20-year smoker, those are firmly entrenched associations. So it's going to take you a while to break them. I'm a big proponent of nicotine replacement treatment. These are FDA-approved medications that deliver nicotine, usually much slower and not via the lung, like a cigarette. What I would advise folks, and again, I'm not a clinician, so maybe Dr. Sadak should be advising and not me, but I guess I would put it this way. You know that there are going to be cues that are going to elicit that craving for a cigarette. A lot of people smoke in their cars these days because it's a place where they can control and are in fact allowed to smoke. So the car itself could be a trigger for cigarette smoking. You know that's going to happen, so let's be prepared for it. Be prepared mentally, as Vasco mentioned, make that negotiation in your head, but also be prepared pharmacologically. Why not have a pack of nicotine gum in the car? And if you get that urge, then you've got a safe and effective method of suppressing it that doesn't involve inhaling hundreds of toxicants.
That's very interesting. Considering that we can't really lock people in a cubicle, you know, or in a virtual reality cubicle for long periods of time. I was going to ask Dr. Good and Dr. Eisenberg also mentioned the nicotine replacement treatments. Pharmacies actually provide smoking cessation treatment. So how can pharmacists help people quit smoking? And what does that smoking cessation program look like? Is it just the dispensing of that nicotine replacement treatment, or is there anything else that is provided with that service?
Yeah, thank you for that. And so when we look at the pharmacists, especially that community-based pharmacist, 90% of patients in America live within 5 miles of a community-based pharmacy. And we know about almost 70% of people visit a pharmacy at least once a month. And so the community-based pharmacist is really accessible, and they can provide coaching, they can provide motivation and support for patients who are trying to stop smoking. And when we look at pharmacists in the Commonwealth of Virginia, they could certainly help patients choose those non-prescription or over-the-counter nicotine replacement products that Dr. Eisenberg was mentioning. So over-the-counter, you can purchase your nicotine gum, as he mentioned. You can purchase nicotine patches and nicotine lozenges. And it's really important to make sure if you're going to purchase one of those to at least have a conversation with your pharmacist, because what I see in my practice in our smoking cessation program is that many times people will try nicotine gum, but they don't use it correctly. And so it's a different art. It's not like chewing a piece of gum. You have to sort of take that gum and you chew it and you park it till you feel a tingling or a peppery taste. And then you chew it again and you park park it on the other side until you feel that tingling or peppery taste go away. And then you chew it again, and you do that for 30 minutes. And you also can't eat or drink 15 minutes before you chew it or 15 to 20 minutes after you chew it, because then you lose sort of that nicotine burst. So it's really working with the pharmacist to make sure you're using products correctly. And then pharmacists should really be asking all patients if they smoke and helping advise the patient on places to quit and assessing their motivation and their readiness to quit. They should be assisting them if they want to set a quit date, and then they could help arrange, access to a program to stop smoking. And we do have some pharmacists who have robust programs where they're seeing patients by appointment. That patient may be coming in every week to 2 weeks, every month, to really provide that support, because it is important to sort of have someone to celebrate your successes and then help you reset and reframe if you've had a slip or a relapse to begin, because it takes many times to really stop smoking. And so asking your pharmacist is a great way to sort of get started with resources if you have an urge to even find some information about how you might be able to stop smoking.
Dr. Good, you've mentioned that this service is usually associated with several sessions with a medium to long-term type of follow-up care. Are smoking cessation programs covered by insurance? Do patients or essentially the people that go into a pharmacy, do they have to pay for the service? Or how does that work?
In some places, a patient may be able to have their insurance pay for it. It's going to depend upon whether or not the pharmacist has a contract with that payer to be able to pay for the services. Some pharmacists may offer, brief interventions without a cost, and we see that a lot. But when you're having a sit-down appointment, there may be a cost associated with that from the pharmacy. But it's really asking the pharmacist if they have the program and what it would cost. When you look at a cost, you can do a quick figure on how much a pack of cigarettes cost and your nicotine replacement therapy, and really you would come out ahead if you have to pay out of pocket typically.
That's very it's very informative. So Dr. Sladak, we've talked about what those triggers are, or that the triggers to essentially go into a relapse. They can be plenty, starting with just getting into a car because it smells like cigarettes, because it's an environment that smokers can control. So if I were to essentially support my family and friends on how to quit smoking, how can I help them? Is there like a period in someone's life that we can say, this is it, this is the right time to stop smoking?
I think that's a tough one because it depends on the person and sort of where they are in what we would call clinically their stage of change. So there's just a way to understand where they are in that process. So are they just thinking about it? Are they preparing to make a change? Like, how are they feeling and what's important to them? And sometimes it takes certain events or things to happen for people to realize now is the time for change. And so sometimes even in talking to people, I ask, what would it take? What would it take for you to decide that you were ready to make this change? And sometimes I'll follow up with, do you want to wait for that to happen? Like, when do you want that time to be? So in terms of supporting people, I think people who smoke, everyone knows it's not good for them. And I think the message is often poured on, and there can be a lot of shameful feelings around that too. And so the strategy for helping someone quit is not necessarily kind of just giving more and more information. It's understanding sort of what is important to them, and even asking, how can I support you in this process? Because it's not easy. So I know that a lot of times stress is a trigger as well. So being a good friend, being an outlet for someone to talk to, maybe leaving a situation if there are triggers to smoke, I think are all ways that you can be supportive. And just, again, I think asking that person and respecting sort of their own autonomy and all of this, you know, I'm here for you. Is there anything I can do to make this easier for you? I think even just knowing you have that social support is a really important thing to have when you're trying to make such a big change in your life.
And speaking of change, you mentioned that people go through several stages of change. I have two follow-up questions. One, what are those stages of change, and how can we, as relatives, as friends, sort of identify those stages of change?
Okay. Well, this comes from Prochaska and Di Clemente. It was, I think, in the 70s, maybe. And they outline different stages. So the first is pre-contemplative. It just means that you're not quite there. You're starting to like mull it through, do even this idea of quitting. You haven't quite gotten to the point where this is something that's really, really occupying space in your mind. And then contemplative is, again, sort of weighing out the pros and cons of change. And let me make sure that I have this right. Then I think is preparation, where you're deciding to make a change. And let me make sure. And that can be things like telling people that you're going to quit, creating an environment, and taking triggers away from your environment, like ashtrays and things like that. And then after that, there's an action stage, which is basically when you set your quit date and you commit to it, and then you do in fact quit. And finally, maintenance. How do you maintain that position? How do you stay quit? And I think that it's not necessarily this like linear pattern for people. People can move in and out of stages, but understanding where someone is, meeting them where they're at, trying to be there as an encouraging person, and also remind them of the things that they say are important to them, I think can help them move closer towards maintenance. And if they do relapse, which does happen, it's part of that journey. And I think that's a big point of support. Some people get into this, what we would call black and white thinking, or all or nothing. I had a cigarette, it's over, I can't quit. And there can be a lot of negative emotions that come with that, a lot of shame. And it can make it very hard to be motivated to try again. So I think just normalizing that it's a part of the process. I think most people, it takes them, I think it's like 8 to 13 tries to quit, and some papers cite 30 tries as sort of the more accurate. But it only takes one time for it to be quit. And it's just about getting there and understanding that it's part of the process, and seeing it as part of this journey. Every time you smoke when you don't want to, you can learn something from that. You can see that as a helpful information for the next time, where you can maybe learn what your triggers are a little bit more. You can prepare for them, and you can have some more strategies at your disposal.
I really like those two. Oh, yes, please.
If I could just add to that, I heard a very distinguished senior smoking cessation researcher give an interview one time, and he said something that really resonated with me. Dr. John Hughes is his name. He said, quitting cigarettes is like learning how to ride a bike. You're gonna fall when you're learning how to ride a bike. But if you keep getting back on the bike and keep trying to ride, you will eventually learn to ride and never forget it. And it's the same for smoking cessation. You're gonna fall, there are going to be relapses. The key is to get back on that bike and keep trying to ride it. And then to go to Vasco's question, if I'm a cyclist, so that maybe that's why this resonated with me. If you're a cyclist and you're helping someone else learn how to ride, when they fall, you don't tell them they're stupid and unaccomplished because they fell. You dust them off, you help them up, and you ask, when are you going to be ready to try again? And I think that's what we need to do. We need to recognize that slips and relapses are part of the process, and that our job as a colleague or friend of somebody who wants to quit smoking is to be there to support them and help them on their next attempt.
I really like the cycling analogy. I was as I was hearing Dr. Sadek speak, I was actually, Dr. Eisenberg's quote about that riding the bike analogy. I was reminding myself of my own running experience. I started running about half a year ago on a very regular basis, and the point I've always thought that running was stupid because it was a painful experience. And what really hooked me was that there was something that made the running experience a positive one. So you end a run wanting to run another one, and that's where people start behaving differently. And I would like to precisely, and then it becomes a habit. Like you have positive experience over positive experience, and then that becomes a habit. So let's focus on the maintenance stage, like Dr. Sadek was alluding to. So we've talked about removing those triggers, or at least becoming acquainted and desensitized to those triggers. Is there anything that we can replace the act of smoking with, or can we initiate a positive habit that can essentially replace that smoking habit? And this is the question to Dr. Sadek, but also to the entire panel as well.
Yes, I think that given that smoking also includes that habit, that automatic habit, I think one strategy that some of my patients find helpful is to replace it with things like carrot sticks or cinnamon sticks or drinking water when they go to a place where, or even chewing on straws. That sounds strange, but something that is not unhealthy, but also could be a replacement, sort of that like oral fix in a way. One thing that I think can happen is that there's just such an automatic grab. So having something else at the ready, for example, when you're in the car where there are so many triggers and you're so used to having a cigarette, just having some sort of replacement can be helpful. And I think it was mentioned before, using the nicotine replacement therapy as well as a really important tool and helpful sort of way to be able to work on that quitting process.
And that's good.
So-
So one of the things
yes,
that we
please.
work with our patients with triggers is a lot of times a trigger is after a meal. So you have a cup of coffee and you have a cigarette. And so it's about either switching the coffee, which sometimes people don't want to do, to tea or something different, or getting up from the table and doing the dishes, going out for a walk. And so it's really trying to see, you know, as Dr. Sadek has said, it's, you know, what prompts me to smoke, and then what can I sort of substitute? And it's going to be individual. You know, some people are willing to do some of the things and some people are not. Sometimes it's hard to change because you're already trying to change, right? So, you know, giving up coffee may not be something they want to do because that's associated with a cigarette, or even alcohol is another trigger for some people. And so it's really trying to figure out what those are and what you can realistically do. And maybe it's just one meal that you get up and do it, and then you get that meal down pat, and then you try the next meal. And so it's really each in stages, and each sort of stopping a cigarette should be celebrated as a milestone to your path to not smoking.
I think that's really important for the people that are around someone that is trying to quit smoking to also know about, because as all of you mentioned, those small successes, the ultimate goal is to quit smoking, but it's the small successes that should also be celebrated and that provide a positive experience. I want to go back to something that that Dr. Eisenberg was talking about at the beginning of the session, is that in addition to the nicotine, there's like thousands of other chemicals in a cigarette. And so one of the things that has been very present in the tobacco market are now vaping products, and then probably the number one attribute that that vaping advocates will probably mention is that, oh my God, this is just nicotine. It's a lot safer than cigarettes. Matter of fact, one of the marketing tools for vaping products was that they can be useful in helping people quit smoking. So About vaping specifically, Dr. Eisenberg. Why do people say that vaping is safer than cigarettes? And are they really?
Well, this is a controversial area these days. So I'll try and answer your question as non-controversially as possible. Why do people say that it's safer than cigarettes? Because they look at the thousands or at least hundreds of toxicants that are in cigarette smoke, and they look at what comes out of the end of an electronic cigarette. It's an aerosol, and they say, well, those chemicals, many of them, are not, the ones in cigarette smoke are not in the aerosol that comes out of an e-cigarette. So it looks safer. And they're absolutely right. That's true. There are no polycyclic aromatic hydrocarbons that are in cigarette smoke that cause cancer. There are, I could name numerous chemicals that are not in the aerosol that comes out of an e-cigarette. However, the trick is that there are still chemicals that come out of an e-cigarette in the aerosol. Heated propylene glycol, heated vegetable glycerin, heated nicotine, the flavorants, almost all of which are generally recognized as safe. That's the term of art at FDA, generally recognized as safe to eat, but have never been studied in terms of their safety once they've been heated and inhaled. And these days, thanks to the advent of products like Juul, there's also benzoic acid in the liquid, which gets heated and inhaled. So when it comes to, are they really much safer? My personal answer is, I don't know. We haven't had the long-term studies to be able to answer that definitively. I would add to that, if the question is, would I expect a 20-year vapor to die of the same diseases that I would expect a 20-year cigarette smoker to die from? The answer is categorically no. I think there are a great amount of diminished risk for cigarette-caused disease. The question is, are they an enhanced risk, and what is the risk of vaping-caused disease? And I think if anybody tells you they know the answer to that, they're being disingenuous, because we simply don't have the data to answer it definitively.
And is it possible, because I'm thinking about just like the gesture of lighting up a cigarette versus using a product like an e-cigarette. You can essentially puff an e-cigarette anytime you want. There's no barrier of like having to go somewhere to light up a cigarette and then smoke it. Is it possible, because you can use it whenever, is it possible that you're just being exposed to much more nicotine than you would with traditional cigarettes? And because of that, e-cigarettes are actually a lot more addictive than traditional cigarettes.
So that's also a complex question. And part of the complexity is that e-cigarettes are really unregulated, although FDA has the power to regulate them and is trying to. And where that becomes important to your question is that some e-cigarettes deliver very little nicotine. Others deliver as much nicotine as a combustible cigarette. Others can deliver more nicotine than a combustible cigarette in the same number of puffs over the same amount of time. And so in that latter category, the answer is unequivocally yes, you can get more dependent on an electronic cigarette than on a combustible cigarette. But to go to the part of your question where you talk about being able to use it everywhere, this goes to the cues that are associated with e-cigarette use, and demonstrates that, unlike in our current environment where a lot of smokers will smoke in their car, smoke on their balcony, smoke outside of work, limited space, and thus limited ability to get these associative cues in particular places. A vapor, if they use everywhere, now has the cues everywhere. And so if they later, either through reasons of health or for economic reasons, decide they would like to quit vaping, my prediction is it's unfortunately going to be much, much harder to do than the already very difficult quitting smoking.
Right. So because if we just look at the characteristics of the population that use cigarettes versus traditional cigarettes, Dr. Good, do we see something in community pharmacy? Do we see any trends in younger patients using more e-cigarettes, and how is that affecting the way that pharmacists provide smoking cessation programs to these populations?
Yeah, so you do see, many of those e-cigarettes were marketed based on, flavorful products, which were, adolescents found enticing. And so you saw an uptake in that. And as Dr. Eisenberg talked about, there's been a sort of an attempt by the FDA to stop that so that those sort of flavorful products aren't available to the adolescent market. So it would impact how a pharmacist could provide nicotine replacement therapy, because you're of the age restriction for also getting those, just like cigarettes. So that would be something that they would have to work with a parent or something with the child as well, to help them stop smoking as well. But pharmacies could also not sell the products as another outlet for some of the different products to decrease the access.
And so, is there any evidence, and this is the question to Dr. Eisenberg, but also to the rest of the panel as well, is there any evidence to suggest that because essentially e-cigarettes are being marketed to younger population, is there any other evidence to suggest that, for example, like e-cigarettes can serve as a gateway to smoking traditional cigarettes? Does that happen? Or is there anything to suggest that?
Yeah, there are numerous studies, one conducted at VCU, but we did a meta-analysis of, I think, 8 or 9 studies that show that e-cigarettes are indeed a pathway towards combustible cigarette smoking. So for instance, you survey people who are using e-cigarettes but not smoking at one point, and say a year later, you survey those same participants and you see an increased risk of having transitioned to being a cigarette smoker relative to folks who never vaped at all. So that is absolutely true. The flip side that you didn't ask about is whether e-cigarettes can help people quit smoking. Anecdotally, the answer is definitely yes. I've met many people who have told me they quit smoking using an e-cigarette. In clinical trials, we published one, there have been others. There is a modest effect, about the same as nicotine replacement treatment, to be honest, from e-cigarettes. In a meta-analysis that looked at all the sort of real-world survey studies and all the clinical trials, the outcome was pretty clear, and that is when they're used in a clinical trial, there is this modest effect that seems to help people quit smoking. But when they're just sold over the counter and people can buy what they want, and remember the huge variability in terms of nicotine delivery that I talked about, they actually are not helping people quit smoking. Which says to me that if they're ever going to achieve any sort of smoking cessation status, it needs to be in some structured way in which the nicotine delivery profile is known. The use is limited to certain places, like the same places you used to smoke, or different places where you didn't used to smoke, but not all the time everywhere. Because then if you want to quit vaping, then it's going to be more difficult. And then finally, we should be definitely putting out the message that vaping as a smoking cessation strategy should be a short-term behavior, not a lifelong behavior, because we don't know what the long-term health effects of vaping are.
So there's a lot to be done in regulatory science in that area. You've mentioned that there are no, as of right now, there's no data about the long-term effects of vaping. Although preparing for the session, one of the things that I immediately remember was the association of the wet lung syndrome and vaping. And then I did some search to see if there's any association. And it seems that the evidence is a little scattered on that sort of short-term effect. Can you talk about what seems to be the likely association between vaping and wet lung cigarette, or specifically the acute respiratory distress syndrome?
I can talk more about the second one, which I think you're referring to what's called EVALI, vaping-associated lung injury. That appeared to be primarily, but not exclusively, limited to folks who were using THC products, cannabis products, in their electronic cigarette, and there had been either intentionally or unintentionally contamination of those products with vitamin E acetate. which causes effects in the lung that can be lethal. But I said not exclusively, and that's really important, because there was an animal study out of Baylor, I think in 2019, that showed even when you just inhale propylene glycol, heated propylene glycol and vegetable glycerin, those are the two main constituents of e-cigarette liquids. Animals who inhaled that showed some of the exact same precursors to lung injury that we're seeing in EVALI patients. And so again, this is why I'm really concerned about long-term vaping and the ability of people to quit should negative health effects emerge. It appears to me, based on the literature I've seen to date, that electronic cigarette use is by no means benign. I can't give you a percentage of how much more, less, or equally lethal it is relative to cigarette smoking. But I really don't, I mean, anything that you inhale into your lungs that isn't air is a challenge to your lungs. And your lungs are not meant to deal with 20 to 200 challenges a day, 7 days a week, months and months and years. They're just not equipped to do that. They're equipped to accommodate gas exchange. That's what they do. And so any challenge you give them, any insult you give them, be it cigarette smoke or e-cigarette aerosol, is going to be a problem over the long term.
I'd like to ask Madeline, is there any other questions from the audience that we need to address?
No, I think that covers it. I'd love to hear any last thoughts that each of our panelists has, though, before we close it out.
Sure, I have a thought. I just wanted to speak to anyone who is looking to quit smoking. I know we talked about a lot of the adverse medical, physical effects of smoking, but I also just want to mention that if you do quit, so much of your health returns. And I think that's an important factor, because I think sometimes people think it's too late for me. I've smoked 20 years, why bother? And actually, a lot of the research and literature shows that there's good reason, there's really good reason, and it's worth it, and it's never too late. And also for anyone who's thinking of quitting now and wants a good starting point, if you track your cigarette use, like self-monitoring is a really helpful first step. If you, before you smoke the cigarette, if you mark or tally, even in the inside of your carton or maybe on your cell phone, that you are smoking, it's going to do a few things. It's going to break up that automatic kind of habit of just grabbing the cigarette. You're pausing and you're giving space for something new to happen. You're choosing to do it. And it also will help you be way more aware of the different triggers to be aware of that might be happening in that moment. So if you're looking for a place to start, I think just self-monitoring. And remember, before you smoke, not after tallying, just even a little check mark. So I just want to throw that out there just to hopefully give a little motivation and to help people start the process.
And that's good. I'll just echo that. I think that that's really an important comment. And the other thing that I want to say is that what I've seen in my practice is a lot of patients who were former smokers, COVID has kind of done them in. And so we've seen some people who've restarted because of COVID. And so if you've done that, try again. I mean, it's begin to think about it when you're comfortable and ready to get back sort of, as Dr. Eisenberg said, back on the bike, and don't let that sort of bring you down, because we've seen that and it's a common occurrence for patients.
Well, all right. I think this is a really good session. I really like the takeaways of, like, if you relapse, you can get back on it. And if you are supporting someone who's quitting smoking, be there, be supportive, celebrate the small victories. And of course, you have at the disposal a huge variety of healthcare professionals, including pharmacists, who are, as Dr. Good said, one of the most accessible, or if not the most accessible, healthcare professional to you. So with that, I yield to Madeline.
Yes, and I'll echo that as well. This was a really great discussion, I think, that gave our audience a lot of good visuals and good first steps for if they are considering quitting smoking to kind of continue in that, and good good thoughts for our friends and family as well, who are wanting to help but not knowing what they can do or where to start. So thank you all again, panelists, for being here and for contributing your expertise. And thank you to our audience as well for listening. If you have any questions after the fact, we'll try to get them to the right people, but thank you for your questions during the session as well. And tune in next month. We're hoping to do a session on aspirin use. So that is all from us today, and thank you for being here. Have a good weekend.
Thank you.